All right, let me introduce you. We are so grateful that we have Dr. Scott LePor with us today. You will now become part of a riveting discussion with board-certified physician Dr. Scott LePor, who found life-changing personal and professional success through trust-based relational intervention, which heals the brains of children with a history of complex developmental trauma. Dr. Scott LePor is a family physician and the medical director of the Texas Juvenile Justice Department. He is a husband, father, and a foster and adoptive parent. Through his experiences as a foster parent, Dr. LePor sought further training through Texas Christian University Institute of Child Development to help heal the life traumas of his children from hard places with the evidence-based neuroscience of trust-based relational intervention. The principles proved to be so life-changing that Dr. LePor now shares his training through lectures and workshops across the country. Welcome, Dr. LePor.
Well, thank you for having me. And I spoke to a smaller group of y'all in the spring. So for those folks, thank you for having me back again. And what I'm going to do is actually present the same material and then expand on it. I think we had like 30 minutes previously, and it is not enough time. We have a great chance. We will not get through the material within even an hour, but I'm going to do my best to get all that I can to you. So that intro, and I need to update the intro, and I'm going to share with you how I got to Texas and in my position. So as I'm a family physician, I never dreamed of working for a state agency, living in Texas. I never dreamed of doing correctional medicine. But I'm going to share with you my journey and how I came into this. So in my introduction, I need to take that out of there. I am trained with Trust-Based Relational Intervention. I am not here to promote that. We're just going to go through the neuroscience of really the Harvard-trained neuropsychiatrist Dan Siegel, who pioneered the field of interpersonal neurobiology. And then there's a lot of other people in that field working at the same time, trauma-informed. Hopefully y'all are getting some trauma-informed information, so you're at least trauma aware. And then trauma-responsive models are, right, we understand trauma, and then we are implementing. And I think that the title that y'all have for it is better. So I presented this at the Texas Institute this last fall, and what I'm hitting is pivotal for implementation if you don't understand. So even with the science, I'm very meta-analytic. So it's just the way I am, but when I read data, I inherently collect the data. And then when I read a study, I incorporate it into the rest of the data. And a lot of times people can take an isolated study and then they start to make modifications or they start to make implementation, but it's a failure model because they're not taking into effect the big picture. So I'm going to walk you through the big picture in a simplified way, and it is not oversimplified. And my gosh, I think they hang meat in here at night. It's freezing. So, anyways, thank you for having me. Typically, if a physician's asked to come speak to a group of lawyers, it's not a good invitation. This is a great invitation. So I'm happy to be here, and this is a great group to hear it. And I can say for the state, I'm on a couple of cross-agency trauma-informed committees to help put implementation of training for the state of Texas on with Dr. Courtney Harvey's here, our great leader for the Statewide Behavioral Health Coordinating Council. I also participate with that, but there's other, and then I also teach frequently to the state of Texas on trauma-informed care. I'm going to share with you how I got here. I'm going to try to do it quick, but I share always because it's relevant. And again, I rejected this model, and I'm going to share with you why, but it's so pivotal because it's changed my life. And then you'll learn why I'm here. And I'm here for the same reason you are. I'm actually here for the model. That's why I moved my family here. So I'm a board-certified family physician. My wife is also a family physician. And we met in medical school. And we decided to get married right before we graduated, right before residency, we got married. We felt, right, we were all excited, and we were like, we felt at peace. We're gonna have kids whenever it happens. My dad's a physician. He's like, you guys are going into residency. That's ridiculous. Like, there's no way you can do it. But we were like, we're gonna make our own decisions. So 7 years go by, no children. Now both sets of parents are like, what are you guys doing to have kids? We're like, we're trying. And we just, again, felt at peace. Like, when it happened, it was going to happen. So 7 years after that, 14 years, my wife became pregnant. And in the interim, we had looked at foster care, adoptive care, and it just never happened, right? We stayed in practice together. We just kept practicing. So my wife is pregnant, and she's like, Scott, I want to stay home. I'm like, we've got the resources. This was huge to us. We really had always wanted children. So she retired. About a year later, we just reflected back on what we learned for foster care, right? So today in the United States, 500,000 children need placement today. So it was like on Father's Day, and I was just reflecting, going, my gosh, you know what? We have the resources, we have the home. I mean, we've got our daughter. We can help. Let's help. So we went through the training, and we went through Faith Bridge in Georgia. We were living in Atlanta at the time, and we were exposed to Trust-Based Relational Intervention, The Connected Child. This is co-authored by Drs. Karen Purvis, Dr. David Cross. And they showed us pictures of this woman helping these children who come from difficult places, and I completely rejected it, right? So I am a physician, and we use hard science. I had the medical model. I had traditional parenting. And I was like, this is nice. I don't need it. And it's psychology, right? So, and by the way, this has changed. But psychology to a physician at the time, soft science, is like a kicker on a football team. Right, like you use it if you have to, but even if they get it in, it's 3 points. Like, okay. So, but I'm like, I just don't need it. And even reflective, because we're going to talk about attachment styles, and I'm embarrassed to tell you this. I shouldn't be embarrassed because it's just reflective of how I was raised and my attachment style, which is the foundation for neural development. But I actually sat there and thought to myself, my gosh, like, again, embarrassed to tell you this, but I thought, man, I'm the perfect, like, they should be so thankful to have me here. Like, I'm a physician. I came from traditional parenting. Like, I am foundationally solid. Like, holy cow. Like, I was just glorifying myself, romanticizing myself. And that comes from, that's a red flag for avoidant attachment style. So, but I didn't recognize it at the time, right? So I reject the model, and but we go through our training. So we were waiting for our first placement, and the state actually came to us. They noticed we were both physicians, so now they had a pair of physicians. They said, Scott and Rochelle, my wife's Rochelle, and they were like, we have a very difficult case. We know it's your first placement. If you say no, we get it, but we really are going to ask for your help here. And they had a sibling group that was already broken up. In this one foster home was a brother and sister. The girl was 4.5, and she was big, 4.5-year-old girl. They're like, that foster home is closing down. Their foster home, they're not going to foster anymore. They're fearing for the safety of their biological children. We're going to split that sibling group up. We're just asking you to take the female, the youngest girl of that. And so we were a little nervous. It was our first placement, but we were also, well, one, I was wrong about how I even viewed myself. I was romanticizing myself, glorifying myself. But so I said, oh, for sure, bring her in. So we had the medical model, right? We did pediatrics, and we had traditional parenting, and so bring her in. So we felt at peace about it. We bring her in. Everything we try fails. And so after... it was probably a couple of months. I was talking to my wife in bed before we went to bed, and she's just in tears sobbing. She's like, Scott, I don't want to wake up tomorrow morning. I can't do this anymore. Biting, kicking, screaming, right, fearing for the safety of our own child. And so I said to her, I said, well, we tried, right? I mean, we did everything we could. We offered all the help that's available to help these children, and she's just not receiving it. So she said, Scott, how about we just go back and try The Connected Child? Remember, they asked us to read that book, and my wife got halfway through it. I was like, oh, okay, let's do that. Then we've at least said we've tried everything. So I went back, started to read The Connected Child. We started to implement, and we had connection immediately. And in 6 months, that girl was changed. So, and I could go into, she was abused, sexually abused. So she had a very aggressive history. She was very in an excited state. We'll go through why that is, but she asked questions all the time, right? And so she had been sexually abused, physically abused, neglected, and she was always in an excited state, and asking questions was her way of her brain. It's precortical, it's not cognitive, but she's trying to gain control of the environment, right? So if I'm asking questions, and it was just daunting. I mean, it was exhausting. So I just remembered that, like, my gosh, when will this ever end? But it just became that way of being with her. But we now had tools, and we now had connection, and she was changing. And I remember it was right before she had reunification with her family. And it was Sunday after church. We went to the pool, and we're unpacking the picnic stuff. And I hear birds, and I hear children playing. And I look over, and I'm like, I don't hear her. And I look at her, and she's just staring at the children playing, staring around, as quiet as can be. Like she was at peace. So that's what we'll talk about. So I started to, right, so for me as a physician, I'm like, my gosh, this is the perfect model for my foster kids in my practice, right? Like this is what I'm going to use it for. Then I started to get everything I could get my hands on: complex developmental trauma, interpersonal neurobiology, the current neurosciences, right? Peter Levine's work, Bruce Perry, Stephen Porges, Bessel van der Kolk, and just started to entrench myself. Well, then I even started to engage into the works like Brené Brown, right? Vulnerability, empathy, and I started to see all these connections. And again, like I was saying, I'm very meta-analytical, so I started just to put this all together, the data. I'm like, my gosh, this isn't, for foster kids, this is optimal human connection, healing, and growth and development. And this is what the data was showing. So I started to implement it not only for foster kids and in my practice, but at home, and then for adults as well. So my adult Medicaid population, by the way, for physicians, and I'm sure we don't have any medical folks here, but this is, adult Medicaid is usually those people struggling through life. And typically this is the group of people that you want to help, but they're very difficult for physicians. Because they have multiple medical problems, they're maxed out on medications. Usually those are more of the abusive medications, and they're maxed out and they need higher dosaging. But now I started to understand their brain and their life experiences that develop their brain states. So, of course, I wouldn't say that to the patient, but in a way, I would just start to ask them, like, they'd come in as a new patient, and they would see all their diagnoses, they would see all the medications, they're maxed out, and they're like, yeah, and it's not really working, it did help at first. And they're like, I know, doc, I'm crazy. And so I'd say, well, hold on here. I said, just tell me about your childhood. Like, how was your childhood like? Just normal. Like, so she was being honest, right? To her, it was normal. And also our brains minimize trauma because it's our way of dealing with the trauma. But so I'd say, really, okay, anything that out of the ordinary, like you just had one mom and dad never moved, did they ever get separated? And she's like, oh, well, this is a real case. So she's real patient sharing this, but she's like, yeah, well, I had 5 dads, my mom married, divorced, 2 of them sexually abused me. 1 was very physically abused. I'm like, how long did that go on? What ages? And then she said the last one was so physically abusive. I remember him getting so angry at my mom. He was choking her. I thought for sure he was going to kill her. She broke away. We ran inside the car, locked the doors. He poured gasoline on the car, lit it on fire, and I thought we were going to die. And then she looked at me and goes, well, gee whiz, now that I say it, it does sound like it was a little difficult. And my jaw's on the floor. So, and I said to her, I said, you're not crazy. I said, you have a normal brain that has responded normally to a very difficult childhood. So I started to teach foster adoptive organizations, and as much as I could on the neurosciences, education, and how to connect, and then the tools of what to do, of how to heal, develop, and connect with people from difficult back. But actually, it applies to all relationships, all ages, and we all essentially will come from some trauma, right? So I started to implement it in my practice. We actually, at our hospital setting, hospitals are also very interested in this talk, by the way. I'm going to UTMB next week to present the same data, but for hospital administration. Because as I started to implement it to these patients that are difficult, what did the hospital start to notice? Scott, you've got less ER visits, better compliance with medications, your no-show rate is less. They called me the unicorn, and this is multifactorial. But they were like, wow, and this was out of 24 outpatient clinics. We had over 100 providers in the outpatient setting, and I was the highest producing family physician, and I had the highest patient experience scores, right? Both very profoundly important to hospitals currently today, right? So reimbursement and all of that. And I attribute so much of that to these principles, right? So anything that is beneficial out of this comes from the science of implementation. I'm not a unicorn. So our hospital setting was going towards budget and very authoritarian. We had an AVP, Associate Vice President, who was making all these budget cuts, cutting staff. So then my numbers go down. I don't have the staff to take care of my patient load. And then he's always asking me, Scott, why is your production going down? Even though I tell him, well, you can do better with what you've got. So I had one foot out the door, right? I'm gone. So I was about to sign a contract with another hospital closer to my home, actually. So it would have been beneficial. And fortunate to the story, that guy gets canned, and then they bring in someone younger, associate vice president. Actually got a picture of him in the presentation. But he stops by one morning after he got the position. He's like, Scott, I just got to talk to you. He said, why do you have all this success? And I've got another question for you too. He said, on your patient experience scores, there's something very odd. And I'm like, okay, well, what is it? I said, they're mailed out. I'm not filling those out. He's like, no, we get that. He said, but what's different is, so I was in a bigger clinic, and we had neurology, orthopedics, internal medicine, family practice, dermatology. It was a big practice close to the hospital. So he said, you have great patient experience scores. We get it. You're probably a nice guy. What we don't get is that out of all the patient experience scores from the other docs, they view the front desk as awful. Your patients view the front desk as wonderful. Can you explain that? I said, I sure can. I said, when a patient comes back and they feel valued, heard, cared for, and their needs are met, the whole thing becomes wonderful. Right? They forget who they actually talk to, but my experience, 5, 5, 5, 5, 5, right? And I didn't get that every time, but I was developing skills to do that. And by the way, what I'm talking about here, if anybody likes FBI negotiation skills, they use the same model currently that I'm going to talk about, Trust-Based Relational Intervention. The old Harvard manipulative model or Ivy League manipulative model is gone, right? Read Chris Voss's Never Split the Difference. He's FBI negotiations. It's the same model. Now they pay attention when people speak. You're not thinking to outmaneuver them. You're actually thinking about what they're saying. And you're trying to get to the source of what their real need is there. And I got to be careful not to go down rabbit holes, or we won't make it past my introduction. But so then they made me a medical director. We started to implement it. We started administration. Our patient experience scores for the hospital were at the 20th percentile before they brought me in, and their provider satisfaction was also at the 20th percentile. So this guy says, Scott, can we implement this within our hospital setting? Absolutely. He said, will it work? The science shows it will. So we started to implement, thank God for him, he implements it right out of the gate. And in 2 months, our provider satisfaction went to the 80th percentile. In 19 months, we were in 90th percentile for patient experience in the country. So I started, so what else? So I started to be consulted by different states, especially the Southeast, for helping with their foster care system and trauma-informed training, and just sharing models and what the science was. In November 2018, I was asked to come testify to Texas state legislators on trauma-informed care in the foster care setting. And then I had to give a presentation at Texas Christian University that afternoon to their child development program. It was actually an invite for the whole campus. So I had to testify first, and so that place was packed. And fortunately, they did let me testify first. So I sat next to the Deputy Executive Director for the Texas Juvenile Justice Department, Chandra Carter. She's now the Interim Executive Director. And she's like, Scott, would you help our medical director become trauma-informed? For sure. So a couple phone calls to him and their nursing director, who's now my nursing director, just kind of helping them. And so then he retires. So they call and like, this model that we're implementing or we want to implement, would you consider moving to Texas? I started looking at homes that day, right? It was now my passion. That's why I'm here. So we're going to go through some of the trauma-informed information. You've probably been exposed to this, but this is what I hit to the Texas Institute. And as we go into a trauma-informed model, I don't want people to miss the most important factor of neural development that trumps our trauma-informed understanding, right? That will help people. And trauma-informed is, if anybody knows Dr. Felitti, right? Kaiser Permanente, this is California. He does this study on obesity. He has a weight loss clinic, and they find that many women that were losing significant amount of weights would hit a point and then they would put the weight back on. So they did questionnaires. They found a root of sexual abuse. And so, right, they were seeing that these women who had a history of being sexually abused, even at the age of 4 or at a young age, would lose weight. Then they start getting compliments, right, from other people. Wow, you're looking good. You're attractive. And it's not cortical, right? It's precortical. It's not cognitive. They would then start to gravitate back to the weight. So those comments went away. So this guy, Felitti, presents this data on trauma and how it affects people to a group of psychiatrists, right? He goes right to the medical field. They all reject it. We don't need to hear another excuse of why people can't lose weight. So thank God Dr. Anda from the CDC was listening to the data, and he's like, oh my gosh, right? He's mind blown, and he's like, you need bigger numbers. So they put together the ACEs study. And by the way, so this is the original ACEs. There's more, right? This is the original 10. If you do the ACE questionnaire, there's more to it than this, and the complexities are deeper than this, because I'll get asked all the time, like, Scott, well, now that we have the ACE questionnaire, do we even need a psychological evaluation? ACE questionnaire, 1, there's more ACEs than originally, and 2, it doesn't take into account severity, frequency, duration, chronological age, which matters because we're going to talk about brain development. And so a trauma at 2 is different than a trauma at 12 by brain development. So just what's impacted in the brain matters. And then resiliency, and this is the pivotal factors. What relationships did they have that were constructive for the brain in a way that allowed them to be resilient, truly resilient? Not in resiliency. So much of this talk is out in the public, but yet it's really poorly understood sometimes. So you'll hear about somebody that goes through trauma, they, make $100 million, oh, they're resilient. But I'm talking about relational resiliency, right? And that's what we're talking about, because I can be just as traumatized or harmful to other people and be very financially successful, right? But we're talking about relational. So to get back to the ACEs, right? So this is the ACE study. The first category is 33%. And this was a nice socioeconomic neighborhood in California. 0 ACEs reported. And then the next category was 1 to 3 ACEs, 51%. The data below is reflective to 3 ACEs. And then you go to the last column, 4 more ACEs. The data is reflective of 7 ACEs. So this is profound, right? So they notice, right, 0 ACEs, that person, their risk of IV drug use, 1 in 480. You go to 3 ACEs, and that drops to 1 in 43. right? And then 7, 1 in 30. Suicide attempts, 1 in 96, 0 ACEs. You go to 3 ACEs, 1 in 10. And then it doubles at 7, right? 1 in 5. So this is what was mind-blowing. And it wasn't even so, let's say, and it carries over to the biological, the physical, right? Your childhood biography will determine your adult biology. And so what they were finding is that, like heart disease, diabetes, and systemic inflammation, well, of course, these people drink and smoke. But they were finding, no, that actually this person doesn't drink at all. They don't smoke, and they run marathons. But they started to notice primary brain inflammation. Like we thought there was only secondary brain inflammation, trauma, toxins, infection, but these people had primary brain inflammation from childhood trauma, and not necessarily physical, but relational. So this became mind-blowing, like, oh my gosh, trauma has more effect on us than we recognize. So this is some of the expanded ACEs, I'm sure many are aware, but living in foster care, bullying, community, socioeconomic, social injustice, all of these things can contribute. And actually, traumas can be well-meaning, right? So if a newborn is admitted to the NICU, right, neonatal intensive care unit, and they're without touch, right, which is the most important neurological factor of brain development, the first year of life, is nurture. So now you withhold nurture, and now this child's receiving pokes and prods and needles. That traumatizes the brain, but it may be very necessary to save the child's life. It's still trauma. I had a patient, man, I'm just going to get myself in trouble, but I had a medical student, loved to teach. This was when I was in practice. I'm learning all of this. I'm teaching the medical student. We go in to see this patient, and I had a cancellation, so they put an internal medicine doc's patient in my schedule, and for something simple. But I go in, and this patient's blood pressure was like 210 over 140 something. So it was high, and I'm like, man, you've got hypertension. Their doc, Max Parrott, man, he was amazing. So I know he had great care, but I was like, man, you might want to get with Max about your blood pressure. I'll give you something for your whatever, and it won't affect your blood pressure, but you need to come back. And he's like, no, we've already gone through this. Max knows. He said, whenever I come into the doctor's office, my blood pressure goes through the roof. And I was like, really? So I look at the medical student, and I'm like, tell me about your childhood. Like, what? And he's like, oh, it's crazy. He goes, I had polio as a child. And he said, the crazy thing is I was only 2 years old, and I don't remember it. My parents would tell me about it, but it's so bad I can be driving through town, and I see a sign for a hospital, and I can feel my heart rate goes crazy, my blood pressure goes through the roof. He goes, but I don't even remember it. And I said, you don't remember, but your brain does. So here it is, right? So brain basics. So with trauma-informed, if you hear about the brain, you're going to hear probably 3 sections of the brain: the prefrontal cortex, and the midbrain, and then the brainstem. Prefrontal cortex is what we're all interested in. It's that complex cognitive thinking, self-regulation, emotional response control, paying attention, and that develops around your mid-20s, completes, right? And then the midbrain is kind of that part of the brain that determines if you're safe in an environment, right? It's kind of like a watchdog. And then the brainstem, which you've all probably heard, fight, flight, or freeze, that's the reactive part of the brain that's based upon survival. So we're all, hopefully I've got you in the prefrontal cortex. You guys are all listening, thinking. We're all right here. But let's say we start to hear some pops in the background. And some of you are trained with active shooter. And your amygdala is now going, okay, so this isn't part of the talk, but I hear this in the background, and it goes, oh my gosh, I know what that sound is. We've got an active shooter. And so the midbrain detaches the prefrontal cortex. Right now, I can be up here talking away, and that brain's not even paying attention, right? It's not learning, it's not focusing, and then it goes brainstem, right? And it goes brainstem for a reason. Like, we want to live today. And I could care less what I'm going to learn, but I'm going to survive. And so I either fight, I'm going to fight the person, I'm going to hide, or I'm out of here, right? If I can. If I can make my way out of here, I'm done. That's the fight, flight, or freeze. So this part of the brain, that prefrontal cortex, and by the way, so I can't go back, but on there, I just love it. And I think I mentioned this to the last group, but it shows the anterior cingulate cortex. It shows the orbital frontal cortex. I don't think it lists, but the dorsolateral prefrontal cortex. But the importance of the development of that part of the brain is actually the reason why we're all here in many ways. And it can be the process of that executive thought and the decisions we come to and how those are resolved. And it all depends on the integration of that brain. So the more good neural integration that I have with my interactions with life experiences, the stronger that integration is. So the example would be this. So the anterior cingulate cortex, by the way, is the part of the brain that we call currently the God part of the brain. Why? Because it's the empathy part of the brain. It shows compassion, kindness, right, gentleness, generosity, and it's developed, right? It's developed. So this is why you want to know, you can see reflectively how people think and how they interact. There's a lot of data on this, and I don't want to get off on it. But so you can just tell those people, wow, they're just the kindest person. And there's reflections of pleasers that it can be actually from traumatic response of why we're nice. But those that really are just that tender-hearted, giving people, they've got a large anterior cingulate cortex. So this is the example, and I think I gave last time, but let's say I'm on the highway with my kids. And right, I'm going through Austin, bad traffic, and somebody just cuts me off. It really almost causes me to get into a wreck. And I've got my 3 girls in the car, right? And I want to go, I'm PO'd, right? And maybe explicatives come out, and I want to ram that guy. But the desire's there. So what's going on in my brain? My amygdala was just triggered, like you were not safe. I want to go fight, flight, or freeze. But the brain is actually in a battle right now, and the prefrontal cortex goes, Scott, you're angry. Just that thought brings me back to the dorsolateral prefrontal cortex, and then it starts to come up with ideas. Well, if I ran that guy, I could get in a wreck. I've got my 3 girls in the car. And I start to make sense of, man, that's a bad decision. So I start to slow down, right? And then it actually goes to the anterior cingulate cortex too and thinks, you know what? I don't know why that guy just cut me off. His child may be in danger. Maybe he's taking them to the hospital. I hope everything's okay. Right? I calm down, self-control, self-regulation, and I actually even end it empathic. That's the anterior cingulate cortex. And I think what I mentioned to the last group is you cannot court order an anterior cingulate cortex. I wish you could, because I'd have you do it for me too. But it's developed, right? And I think the example I gave last time, right? It's not what you tell an individual. So if you tell a child their whole life, right? Caregivers say to their kid, hey, speak French. Speak French. Dadgummit, how many times do I tell you speak French? But the whole childhood, those caregivers are speaking Spanish to the child. Guess what language that child's going to grow up speaking? Right? And I fell into this trap. So as a physician, they bring in their child with behavior problems. And the kid's got the problems, but the parent would say something that, right, we just gravitate as yes. I tell my son, man, he's got to be honest, hardworking, do the right thing. That's what we teach in our home. And I'd say, kid, listen to your parent. You got a good parent there, and they're telling you exactly what you need to know. And I'd go, the kid's making bad decisions, right? So now I know, right, because now with what I know, the parent's like, right, that's not how I raised my kid. And I'm like, well, kind of is. You don't think you are. You think you stand for those, but what that kid has experienced is exactly what they're doing, right? And you can see this on social media all the time with bullying, right? A parent bullying the child because the child was bullying at school. They're learning to be a bully. Like, so you can't tell someone to speak French without ever learning the language. I'm going to speak what I'm exposed to, what I'm immersed in. And if you can speak French without ever being immersed into it, like go on the road. You'll make a lot of money because that's a miracle. But so I love this model, right? It's a construction of a home. And this comes from Dan Siegel's and Tina Bryson's model. Dan Siegel, again, that Harvard-trained neuropsychiatrist. But it's really construction. The brainstem at birth is almost completely developed. And And there is framework, right? So there is a complete brain, 100 billion neurons waiting to be wired, but it's life experience that largely there is genetic influence, but it's largely life experience. And that becomes epigenetic right above the gene. So the experience either shuts off gene expression or turns it on, but it's the experiences I go through. But this becomes the pivotal point that I want to make, is that it's the foundation of the home. And what's it dependent upon? The resources that that caregiver has or the builder has, and their skill set. So it's the construction of the home that will determine how it handles a trauma when it goes through it. Right? Think of it this way. So if I have, Hurricane Ian or whatever that just went through. I barely pay attention to Sliver of the News. I apologize if that's not even correct. But so a hurricane recently goes through, and on one side you have hurricane industry standard homes built, right? I mean, beautiful homes that are solid. And then you have a mobile home park on the other side. Hurricane goes straight down the middle. Proximity is equal. Right? One's destroyed and the other one maybe has some damage but withstands. That's the brain. So that's what I keep telling when I share, like, yeah, let's talk about trauma. But the most important factor is what's not there. So if you don't give the individual what's not there, what's needed, like, good luck dealing with the trauma. So here it is, right? This is the pivotal point. Man, this comes from John Bowlby, 1940s, secure attachment theory. And so, like I said, right, psychology used to be a soft science. Now we have functional brain imaging, neurotransmitter profiling, and it's a hard science. Like, now we know. Now you can go back at these observational studies and throw out, right, oh, that conclusion was wrong and this one's right. It's amazing time for neuroscience. But here it is, right? So you have a child who cries, right? Brainstem almost completely developed at birth. And let's say this child is hungry. Excitatory neurotransmitters, sympathetic nervous system is firing. And you have a caregiver in this situation that knows the cry and comes and feeds the child. And it actually matters how they engage. So this caregiver, actually, it's like connecting. It's just very wonderful connection. I'm feeding the child. There's interaction. And now you have parasympathetic nervous system, calming neurotransmitters, and you're scaffolding the brain. So now the brain is learning that when I have that feeling of hunger and I have milk, that goes away, right? But after 1,000 times, and now my child's 3 and says, Daddy, milk, I need milk. And then at the age of 10 can then go to the kitchen and pour themselves a glass of milk. And in my home, it would be plant-based milk. But there it is. That's the scaffolding in the brain, and that's how it develops, right? It's through experience. So think of this. Now you have a child who is hungry, expresses a need in the sympathetic nervous system, excitatory neurotransmitters, and the parent has poor neural integration, and instead of making a good decision, is triggered. And they go brainstem. Dad, get right. And by the way, a crying baby is harsh on the brain, right? It's used as a means of torture to people. And that's true, right? So now you have this child screaming, crying, and I've got a distressed caregiver who has poor neural integration, and they go brainstem. I'm either going to hurt that child, I'm going to do drugs, I'm shutting down, right? Fight, flight, or freeze, I'm out of here. So all that's going on, where's the child? No completion of the cycle. They're brainstem. They're still brainstem. What's developing? The brainstem. So now you can see where the brain of the parent, very strong reactive person, because the brain has poor neural integration, the prefrontal cortex, by the way they interact with the child, the brain of the parent becomes the brain of the child. And now I have a reactive child, right? This is how we see generational trauma. But you take that child into a secure home, and it's not always a foster home, by the way. Foster homes can sometimes be more traumatic than the original. But if they are fortunate enough to be in a foster home that gets connection, then that will change the brain. And usually attachment's determined by 12 months of age, by the way. I don't know that we'll get to it, but hopefully we can. So it even is reflective in parenting styles. This is what the data shows. Authoritative is really that secure attachment style. Right, the parent is in control, but it is a more cooperative, understanding, always chase the why. Authoritarian, this is how I was raised, right? It's my way or the highway. Right, these children that grow up with that, it's like high structure, but no nurture. The effective means, like secure connections, always high structure, high nurture, and it's not good cop, bad cop either. So this is where people, if you grew up authoritarian and you hear this model, just like I did originally, and you don't know what authoritative is, you'll think permissive. Oh, so I'll give these lectures all the time, right? And the parent comes in and I'll teach about authoritative, and during break they come up and say, oh, so you think the child should be in control and run the home? Nope, that's not what I said. Please don't do that. It's a failure model. And permissive will think, oh, so some structure in home, we should be mean and harsh to kids. Nope, not what I said. But the reason that they think that is because they always think the opposite of what I was raised with, right? Or if a parent determines, you know what, I don't like the way I was raised, I'm going to do the opposite. You'll go from the left ditch to the right ditch. Because I don't know what I don't know, right? And I would teach with foster care, and I remember one gentleman goes, yeah, we're all secure here probably, secure attachment. I said, well, actually the data shows that if you want to get involved in foster care, you have an 84% chance that you're insecure attachment. And that includes me. So he would say, but yeah, well, when I was raised, I was raised a very difficult childhood, but I do the opposite. I said, how do you do the opposite of what you don't know? He said, well, that's a good question. Well, think about it. So here it is, right? So what does fear or aggression do to the brain? The amygdala determines that I'm not safe. Guess what gets detached when the human being determines they're not safe? The prefrontal cortex. If we want to train, educate, help people grow, guess where they need to be? Prefrontal cortex. Can you change behavior without the prefrontal cortex? Yes, you can. It's called North Korea. Kim Jong-un is doing it effectively, right? And I'm for real, right? Like I can control you, but it's not implicit. Like it's a fear-based behavior change. And again, it's not all hugs and kisses. Like it's a high structure, high nurture. So if I were to give a summary of the model, it's this. Like there are boundaries, and we must remain safe. Boundaries are here to keep relationships healthy. And but they're not here to separate us. Boundaries are here to keep us connected and healthy. And if you ever bump a boundary, I will never harm you, shame you, intimidate you. I'm always here to help you, guide you, protect you. If you want to think about it in law enforcement, it would be a crisis intervention trained officer, right? So they show up, they're not here to co-escalate the situation. They're trained to remain calm, right? What's calm? Prefrontal cortex. So you have an escalated situation, and if I come in and I escalate, I take things personal, I co-escalate, and then something's going down. But if I come in and I'm calm, hey, sir, ma'am, how can I help you here today? But authoritative stance, right? And I do have authority, but I'm gentle, kind, I just want to know what's going on, I'm here to help you. Sir, could you please put that down? Like before we talk, I do want to know what's going on. I just need you to put that down. But when they feel safe, they'll comply, right? But if I come in gun loaded, what am I going to do to the brain of the person already escalated? Like it's going south. So I'm going down rabbit holes again. Sorry about that. So repetitive trauma, right? So for a lot of these kids that hit DPS or the justice system, repetitive trauma overdevelops, right? I'm reactive, brainstem. I can be compliant in front of you. As a matter of fact, you ever want to watch an effective model, and it does happen to be TBRI that they used in the model, came out of Tyler, Texas. It was a documentary. The executive producer it was NBC Weekly or whatever. I mean, it was very well done, but it's called All Rise for the Good of the Children. Man, you want to watch that because it's exactly it. Like, this is okay, this is not okay, but we're here to help you. This is the ideal model for reunification, right? Giving hope and the tools for the caregivers and the youth to have a better trajectory. I'm going to kind of fly through it. So this is extreme neglect. So you can see the lack of neural development just based on neglect. Is when I said that the most important factor for neural development the first year of life is nurture, there was so we know that now, but there was a study done back in 13th century. King Frederick, who was a German king, did one of the first studies that I know of reflective of this. And so he believed that all humans would speak German. German was the primary language. The reason why people don't speak German is because they're influenced by others talking in languages that aren't German. And so he had a group of children, and they were fed. We want them to survive, but nobody touched them, nobody talked to them, and when they grow up, they're going to speak German. Unfortunately, the study failed because they all died the first year of life. And the conclusion of the study was they all died for want of petting, touch. Right? The human doesn't survive without connection. Isolation has irreversible neuronal damage in the brain. Synaptic connection. So solitary confinement is actually harmful to the brain. But they've lacked nurturing care as well as received trauma. I think the point here is they act much younger than their age. So talk about neural development, right? Now the construction of the home. This is why, like especially in my setting, you can have a 16-year-old who acts like an 8-year-old, but yet they have the street smarts of a 39-year-old. But it's, and they'll want to go back to that. When we had our 4-year-old girl, man, when I first learned this, and I'll never forget, but right, I was trying to correct her behavior and mode originally. Then I changed as I started to learn more and more. And it was time for dinner, and my daughter's probably around 2 at this time. And I'd carry her into dinner, but I'd tell our foster child, come on, and being, right, that proactive parent, caring and drawing her in. And she's like, I want you to carry me too. And I said, you're 4.5, you can walk. So, right, so I was trying to control her controlling behavior because she was controlling. But I was going to show her, well, right, I'm in control, you walk. So then I learned this, like, oh my gosh, like, maybe she just wants to, like, she didn't get that. So the next time she asked, I said, Rochelle, grab Rachel, carry her in, and I said, well, I won't say her name, but I said, do you want me to, you want to ride on my shoulders, or you want me to carry it like Rachel? And I'm thinking, right shoulders. And she's like, I want you to carry me like Rachel. I put her in my arms, and she almost fell asleep. Like her brain craved what she didn't get. But man, her behavior was half her age. But it started to make sense. We see this all the time in the juvenile justice system, right? Now we start to use the neurosequential model of therapeutics, right? So we go back to the family history, the age. This is Bruce Perry's model of where you're actually getting brain imaging based upon medical history, family history, when did the trauma occur, what's resiliency factors, did they have anybody in their family that was a safe connection? And then cortisol's damaging. I'll show you this quickly. So this is secure child, right? They have sympathetic, they have parasympathetic, but they get a lot of that special love that's not even solicited, right? Good morning, sweetheart, pancakes on the table, tickle, fight, whatever. But it's just, right, wonderful things that happen. And so what that does to the brain is when a child is loved in a healthy way, the brain perceives itself as lovable. Right, I am lovable, and it's precortical. Like, it's not something that people tell you, go, okay, I'm lovable. Like, it's implicit. It's felt within. So I feel precious, I feel heard. They will go through life with difficulties. So here we have sympathetic arousal, that parasympathetic. So I go through my day of difficulties. I forgot my cell phone, or the traffic's bad. But I get through life, right? And I make decisions that help me get through those difficulties. So that's what a healthy relationship does. So if I come from a difficult place, right, and I have a lot of trauma, and I have a lack of that developmental portion of my brain that actually allows resiliency, so it's not there. I'm the mobile home that went through the hurricane. Right, so then I have a trajectory of mental health problems, behavioral dysregulation, ADHD, and it's multifactorial. There's other reasons why. But man, if a brain is in an excited state, right, so it's always fighting, like, am I safe here? Right, that's Matt Damon in that Born Supremacy maybe movie. I just remember, like, it was exact. It's a great analogy, right? So he's trying to figure out who he was, right? He's this trained killer dude or whatever, and he's in a restaurant with somebody there who's having a piece of pie and having conversation. He's like, why do I know where all the exits are, the license plates of the car, people facing, like, he's scanned the whole area, right? He's like, why did I notice that? That's someone who comes from trauma. No place is safe. And what fires together wires together, and that comes from Donald Hebb, 1949, by the way, neuropsychologist. But what I experience in my life becomes hardwired. That's the person who has polio, has a bad experience. I don't even remember, but my brain does. So they go through life like this, right? Lack of that prefrontal cortex, that anterior cingulate cortex, dorsolateral prefrontal cortex, orbital frontal cortex, and they don't make decisions, they react. And they're either all the way on or they're shut down. So what will punishment do to this child? Punishment doesn't teach. Punishment does block behavior, but it doesn't teach. And what do these kids need is effective teaching, right? They need construction of the brain. An easy example of this, and by the way, I came from a belt in the drawer family. I mean, that's the way I thought I had to be as a parent as well, right? That's parenting. But man, it started to make sense to me. It's so logical, the data, but the data is just profoundly conclusive, like, and it's just logical, right? So think of if you want to go play golf, and you want to learn to play golf. So you go hire a good golf instructor, right? So I get up there, and I don't really know what I'm doing yet, but I've kind of seen some things, and I go to hit the ball, and it goes flying straight that way, right? Almost hits a guy. And my golf instructor walks over, bam! Why don't you just go sit down over there when you're ready to come back and hit that golf ball down the fairway with a smile on your face? Because you should maybe be happy you're even playing golf. You come back and let's play golf. Right? So now I'm nervous, right? What's detached? The prefrontal cortex. Now I'm even kind of scared. I may even not even hit the ball. And then he does it again, right? Now we're disconnected. I hate golf. Right, I'm not doing this, and I don't learn how to play golf. I'm not an effective golfer. He may sign me up for a tournament. You better play well. But the opposite's true. So permissive doesn't work, right? All nurture, no structure. So let's say I do get a cute little golf instructor, and she's like, okay, Scott, let's do it. And I swing, and I miss it completely. And she's like, oh, you're the champion. Whoa, keep going. I'm like, really? Okay. And I'm hitting them everywhere, and I'm like, both, right? So this is where permissive data shows that these people actually have a strong self-conscious awareness. Like they really think that they're better in life than they truly are. But they've been given a lot of nurture without structure. But 3 months later, hopefully I come to the conclusion, my gosh, I can't golf. She's not helping me at all, other than my self-esteem. But what's a good golfer? High structure, high nurture, right? So I missed the ball, and they're like, whoa, Scott. Stop. I see what you're doing. And he walks over, and he grabs my arms and pulls it back. He said, you feel that? I sure do. That's way different than what I was doing. Okay, let's swing it through. And it's not a great shot, but it goes towards the middle of the fairway. And I'm like, my gosh, we're connected, closer together, and he's wiring my brain to be a better golfer. And there it is. So when we have dysregulation, like, what's missing? Right? We know the science now, right? You know what belongs there. But what do we sometimes offer? Man, I want to hit one video before because I did run out of time, right? Is it permissive or dismissive? Oh, they're fine, whatever. Or is it the anger, punitive, right? It's not. both will continue the sympathetic, excitatory, doesn't wire the brain in a constructive way. So what does? High structure, high nurture, right? This is okay, this is not okay, but this is how we do it. And it's not good cop, bad cop. And this is where, man, our agency, the direct care staff, they just have a hard time, right? Because now if you're telling me, oh, there's no control, I guess the kids can do whatever they want. It's no. So it's like the crisis intervention trained officer, right? This is not okay, right? In our home, no hurts, have fun, stick together. But if my daughter kicks my other daughter, whoa, 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 no hurts. But I don't come after her either. But I'm like, whoa, 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 that's not okay. That has to stop immediately. Rachel, it's okay to be angry. It's not okay to be angry and kick somebody. Let's learn what to do when you get angry. She took my toy. I get it. That would be frustrating. What can you do that's not harmful to yourself or other people? And let's work on it. Because you're going to get angry, right? And I used to believe the way I was raised, if you were angry was bad. Man, it's just a human emotion. But I need to learn what to do when I do get angry. Oh, well. This is a video. I'm not going to show you because we are out of time. But addiction is a byproduct. This is a great video, and I'll give you the summary of it. But back in the 70s, there was research done where they took rats, and they took a specific rat, but that I forget. But they put the rat in the cage, isolated. They offered it water and drugs. The rat chose the drugs, eventually died, became addicted, and then died. Drugs are bad. And by the way, illicit drug use is bad. But drugs are bad, war on drugs started largely from this data. So Bruce Alexander, another researcher at the time, who frequently used these rats, goes, oh my gosh, they're communal. The rat shouldn't have been used in that experience, but if you take me and put me alone in an iron cage, like, I'm choosing drugs. So he wanted to do a better study. So he put these rats together in their own community, what they needed, and he offered drugs and water. Not one rat chose drugs. Then he took the study a little further, and he took the rat and he put it in the cage with drugs till it was heavily addicted, I think for like 58 days. I mean, they're hooked. Then he took that rat and put it in that rat park. It's called the Rat Park Experiments. And eventually the rat weaned itself off of the drugs and never went back. No therapist. No, not to knock therapists. I mean, this is my field. But, right? But it was connection. It's community. Man, Google the 80-year Harvard study. What matters in humanity? And by the way, this whole caregiver model and that was the point that I actually wanted to make, which I don't even know that I did, but it's a caregiver model. It's how we interact. Think about the 4-year-old child in my home. I had my education, right? If I was on a panel and I said, you guys be the judges. I'm a physician. I come from a secure family, traditional parenting. I offered this girl help. She's 4 years old. She didn't take it. She still has the bad behavior. Who's to blame? Oh, of course, the child, right? But when did the child change? Only after I did. It's a caregiver model. We see this reflected within nature, right? If anybody knows the dog whisperer, Cesar Millan, love Cesar Millan. It's the exact same model. And it's reflective in nature, right? So this guy's on National Geographic. He would get called to these homes where these dog lovers, right? They would have dogs have this erratic, maybe aggressive behavior. And he would come in and he wouldn't even have them tell him what's going on. And then they would just say, tell me what's going on. And then he would resolve the situation and the dogs would go back to normal behavior over time, right? His meme is this: I train people. I rehabilitate dogs. He didn't come in to train the dog. He trained the people to interact in a way that the dog was reflective of being in a pack, right? Because if you don't interact with a dog the way it's designed to be interactive with, it's going to have abnormal behaviors. So he trained people and then rehabilitated the dog. It's a caregiver model. So, and Dr. Harvey, I know she's here somewhere, right? We do all this work, right, to get into mental health. I work with HHSC's community mental health. There are folks. We do want to help with mental health, and we want to work on those facilities for community care. But you know what the most pivotal factor we can do to help people who come from trauma or difficulties It's every interaction we have with them, because this never goes away. Even though attachment style is set by 12 months of age, it can change depending on the influence, and it only takes one person. But after 1,000 interactions with people that are caring, connecting, staying out of judgment. By the way, there's 4 factors for empathy, research shows, and it's staying out of judgment, perspective taking, resonating a feeling within myself that they must be going through, and connecting with that person. But it's not judging where they came from. It's, man, I'm going to help you where you're going. And we want you to be safe to yourself and to others. Right? It's not permissive. And by the way, this becomes polarized. And I am not political. I am data-centered. But this can become polarized, right? So one is, I'm going to punish the behavior until it's gone, or they decide to change. But the other one is, let's just let them, oh, come on, they come from trauma, let's just let it go. But that's permissive. Both are failure models. So where's the hope? When they bump our system, we know there's need. And if it's a youth, you know that the family has need. It's once we start to give them tools to develop better trajectory in life, then there's hope. And there's hope because there's implicit change. And man, you guys are going to have me back because there's a lot more. But